Thank you so much, honorable chairpersons and all esteemed colleagues who are in the hall. So I am going to take you through this topic, which drugs and why should they be stopped during preconception, pregnancy and lactation. So my objectives today are to understand the rationale for modifying drug therapy in reproductive phases, to identify drugs contraindicated in preconception, pregnancy and lactation, discuss safer alternatives and clinical guidance, and at the end provide endocrinologist perspective on high risk therapies. So we'll move to see some core principles which guide us as to the choice of drugs to be stopped during preconception period. So we'll begin with a comprehensive medication review. We'll look at the existing prescription or over-the-counter drugs that the patient may be consuming, supplements and other herbal products. Ask about duration, indication and response to therapy. Identify drugs known to affect ovulation, spermatogenesis, libido or implantation, and discontinue. Ideally, we should be discontinuing all teratogens 3 months prior to a planned conception. So this is an exhaustive list, and there are 2 slides dedicated for creating this table of drugs to stop preconception. However, because of want of time, I will cover only the red arrowed medicine. So isotretinoin the reason for stopping is severe teratogen issues like craniofacial, CNS and cardiac defects, and it is mandatory to use dual contraception when a lady is taking this particular oral tablet, 40 milligram tablet for very resistant acne, and that dual contraception should be in form of a barrier and a OCP. And one month washout is again very important. So methotrexate is an immunosuppressant which can cause neural tube and skeletal defects, and 3-month washout is again very mandatory for ensuring safety of the conception process, and supplementation of folate in high doses. Then AC inhibitors and ARBs, they can cause renal egenesis and skull ossification defects in the fetus, and so it's better to switch to labetalol and methyl dopa preconception. And warfarin can cause fetal warfarin syndrome, which is includes nasal hypoplasia and bone stippling, and the ideal recommendation is to use low molecular weight heparin instead. Now statins is a category X drug and is to be avoided. CNS and cardiac anomalies have been identified. Lifestyle changes, or if at all there is a gross indication, then we may think of using bile acid sequestrants. SGLT2 inhibitors like AMPA and all the rest can cause skeletal and renal abnormalities in animal studies that has been reported. Ideally, they should be stopped. Insulin is preferred. Similarly, for GLP-1 receptor agonists, limited human data, potential fetal risk. So better to switch to insulin. High dose NSAIDs, they can impair implantation of the fertilized ovum and can induce risk of miscarriages. So use cautiously if needed. Prefer simple paracetamol. And paroxetine as an SSRI is to be avoided. It increases the risk of cardiac malformations, and it's the preferred agents in this situation are sertraline and fluoxetine. So what are the key factors underlying the physiological basis for drug risk in pregnancy? So first is placental drug transfer. Drugs that are lipophilic, low molecular weight and unbound to proteins readily cross the placenta. The examples being phenytoin, valproate, warfarin, they cross easily and are all potentially teratogenic. And the safe example here is that of levothyroxine, which is highly protein bound, and there is a minimal transfer across the placenta. Second factor is fetal vulnerability by trimester. So first trimester, that is weeks 3 to 10, is a phase of organogenesis, highest risk of structural malformations, and drugs like methotrexate, isotretinoin can cause neural tube and craniofacial defects. In second and third trimester, God forbid, if AC inhibitors are not withdrawn or accidentally consumed or NSAIDs are taken in large amount, it can lead to oligohydramnios and renal failure. Last, the third factor for physiological basis is altered maternal pharmacokinetics. So increased GFR and renal clearance can lead to an increased requirement of insulin and reduce plasma concentration of labetalol. Increased hepatic metabolism in the mother may increase clearance of anti-epileptics like lamotrigine, and delayed gastric emptying and altered pH in the mother can affect iron and calcium absorption. And this is a list of endocrine drugs to stop. Now we are proceeding towards pregnancy. Oral anti-diabetic agents like sulfonylureas because of the risk of neonatal hypoglycemia and poor placental circulation, so it's better avoided. Insulin is the preferred choice, and in select cases metformin. SGLT2 inhibitors has potential renal and bone adverse fetal effects, so stop preconception. GLP-1 receptor agonists like semaglutide or other agents, they have insufficient human data and embryo toxicity has been proved in animals, so they are best stopped 2 months prior to conception. And agents like spironolactone can cause feminization of male fetus and they are best avoided. Consider alternative antihypertensive agents. So, what are the preferred anti-diabetic agents in pregnancy? Insulin is the gold standard across trimesters. Metformin in select cases of PCOS in first 4 months of gestation, and in some cases of GDM, some of us may be tempted to use metformin when the patient flatly refuses insulin. But we need to critically monitor the glucose levels. What about antihypertensives? So, AC inhibitors can cause renal agenesis and oligohydramnios. ARBs can cause skull hypoplasia and neonatal renal failure, and direct inhibitors which have fallen out of favor, they have been known to be teratogenic in animals. So, what are the safer alternatives? Methyl dopa, labetalol, nifedipine slow release, and in certain situations hydralazine. What about lipid lowering agents? Statins are category X to be totally avoided, contraindicated. PCSK9 inhibitors, there is no human data, so it's better to stop. And ezetimibe has shown animal risks, so it's again recommended to be discontinued. Strategy is to hold therapy during pregnancy and monitor postpartum. What about anti-epileptic drugs? Valproate has known to cause neural tube defects. Carbamazepine and phenytoin moderate teratogenicity. Lamotrigine is a safer option, but we need to cover these ladies with an extra supplement of folic acid to the tune of 4 to 5 milligram per day. Psychiatric medicines like SSRIs are generally safe, but avoid paroxetine. I have already alluded to that. Lithium is known to cause tricuspid valve abnormality known as Epstein anomaly. Benzodiazepines can cause cleft palate and withdrawal symptoms in the neonate. So, infants exposed to benzodiazepines chronically in utero may experience neonatal withdrawal syndrome, which can appear days or even weeks after birth and include tremors, hypertonia, and hyperactivity. So, it's always better to assess the risk benefit properly, analyze it, and then institute a medicine. Then dermatological, we have seen most of this, but again that was preconception. Even during pregnancy, strictly to be avoided. Isotretinoin, methotrexate, mycophenolate is known to cause ear and facial defects. Stop 6 weeks before planned conception. If at all unavoidable, use azathioprine or hydroxychloroquine. Anti-infective agents include tetracyclines. They can cause, example is doxy. It can cause tooth and bone growth inhibition. Fluoroquinolones can cause cartilage damage. Sulfonamides can cause kernicterus if used in third. You are tempting me. Don't eat in my presence. In the third trimester. And what are supposed to be safe are penicillin, cephalosporins, and erythromycins. Then what about thyroid and pituitary medications? So levothyroxine is safe and essential. In fact, dose normally needs to be escalated. PTU is preferred in first trimester for Graves. Methimazole can, if used in first trimester, it can cause aplasia cutis and coanal atresia. Coanal atresia is nasal airway blockade. And aplasia cutis is a sinister skin condition. There is an absence of skin over the skull. So use PTU in first trimester instead, and methimazole is relatively safe in second and third trimester. Dopamine agonists like cabergoline and bromocriptine may be continued if you find the prolactinoma very symptomatic in that particular lady. In desmopressin, which is a synthetic analog of vasopressin, it can be used for control of symptoms in central diabetes insipidus. What about bisphosphonates? So it's a long skeletal half-life they enjoy, and that is why there is a potential to fetal bone toxicity. So they are better avoided. We should opt for optimum calcium and vitamin D supplementation. Lactation considerations. So we need to remember the risks depend on drug lipid solubility, protein binding, and oral bioavailability in infants. So drugs generally compatible with breastfeeding are insulin, metformin, levothyroxine, labetalol, heparin, PTU, and very low dose of methimazole. And drugs to avoid or monitor closely, you require, for example, cautious use of SSRIs, metro, and lamotrigine. But sulfonylureas can cause risks. It can cause induced neonatal hypoglycemia, and GLP-RS and SGLT2 inhibitors, there is a limited data to recommend during lactation. And so this is a list which is totally to be avoided even during lactation. Includes amiodarone, it can cause thyroid and cardiac effects. Lithium can induce neonatal toxicity. Ergot alkaloids can suppress the milk formation, and chemotherapy are a big no-no. So clinical pulse before I, Honorable Chairperson, I am shortly ending my presentation. Case 1, there is a case of PCOS on metformin and isotretinoin. So what is the recommendation? Stop isotretinoin 3 months before planned conception. Case 2 is that of a hypertensive lady on losartan. Pregnancy either is confirmed or she is planning proper conception and pregnancy. Ideal situation would be to switch to labetalol and methyl-dopa. Third is epileptic lady on valproate, replace with lamotrigine and start folate very early. Case 4, type 2 diabetes on metformin plus empagliflozin, planning pregnancy. So we need to stop SGLT2, continue metformin if needed, consider switching to insulin, which is the gold standard advice. And the last case, Graves' disease on methimazole, then the pregnancy, once it is confirmed, switch to PTU for the first trimester. So the key takeaways from my humble talk, always weigh maternal benefits versus fetal risk. Preconception counseling is essential. The DCGI and CDSCO, that is Central Drug Standard Control Organization, they still continue to follow legacy A, B, C, D and X classification, which is the older given up classification in the US. In fact, the FDA in 2015 has proposed pregnancy and lactation labeling rule, which we should be following. Other online sources are LactMed and BRICS Guide, and multidisciplinary collaboration is the key. So thank you very much for your patient hearing. If there are any questions, comments or criticism, everything is welcome.